up on the dance floor tonight. I got 2 left feet and a bottle of red wine, making me feel like the beat in the bassline are in my blood, both hands up on the waistline. Get on up, baby, dance to the rhythm of the music. Don't care what the DJ chooses. Get lost in the rhythm of me. Place don't close until we wanna leave it. You and I were flying on an aeroplane tonight. We're going somewhere where the sun is shining bright. Just close your eyes. Let's pretend we're dancing in the street in Barcelona. 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 Get up on the dance floor, move. It's a Saturday night. I fell in love with the sparkle in the moonlight, reflected in your beautiful eyes. I guess that is destiny doing it right. And dance like they do in the Mediterranean, spinning you around me again and again. You're like something that God has sent me. I want you, baby, solamente. You and I were flying on an aeroplane tonight. We're going somewhere where the sun is shining bright. Just close your eyes. Let's pretend we're dancing in the street in Barcelona. 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 Oh, Barcelona. So let's pretend we're dancing in the street in Barcelona. Las Ramblas, I'll meet you, we'll dance around La Sagrada Familia. Drinking sangria, mi niña, te amo, Macarena. Mamacita, rica, sí, te adoro, señorita. Nosotros, vive la vida. Come on, let's be free in Barcelona. Las Ramblas, I'll meet you. Come on and dance with me in Barcelona. Drinking sangria, I just want to be in Barcelona. Mamacita, rica, feel that summer breeze in Barcelona. Nosotros, vive la vida, siempre viva Barcelona.
Kapal di Indonesia, menuju Indonesia maju sejahtera. SMEC Group majulah, SMEC Group jayalah, SMEC Group pilihanku, SMEC Group tukang sapu.
We're so excited to tell you that at this moment, we have near 1,400 participants from 85 countries and 6 continents around the world.
That at this very moment, we have nearly 1,000 participants from 63 countries across 6 continents around the world.
We are so excited to inform you that at this very moment, we have more than 1,000 participants from 76 countries across 6 continents.
So we are very excited to inform you that at this moment, we have more than 1,000 participants from 74 countries across 6 continents around the world.
We would also like to inform you that at this very moment, we have more than 1,000 participants from 81 countries across 6 continents around the world.
We would like to inform you as well that at this very moment, we have nearly 1,000 participants from 65 countries across 6 continents around the world.
We would like to inform you as well that at this very moment, we have near 1,000 participants from 61 countries across 6 continents around the world.
Time is yours. 5, 4, 3, 2, 1. Lift off. Let's go.
Thank you very much. It's been a great pleasure to speak with you. Nice to meet you over Zoom. It's interesting that we meet people now across the world all the time.
And live off. Big applause to Amar Agarwal.
Thank you very, very much, first of all, to entire Indonesia and also to all the 1,400 delegates watching from 85 countries.
Applause. Godspeed, Mother Jersey.
Thank you very much for this extremely kind invitation and of course a very beautiful introduction. Thank you very much.
Time is yours. Live off. Ahead, police.
Thank you very much. First of all, I want to thank Gede, Pardianto, and all Indonesian ophthalmologists that were being so kind to invite me.
Applause.
Thank you so much, really, for organizing something like this, because it really kind of opens up so many channels of education.
Live off. Applause. Godspeed, Oliver.
Thank you very much for the very kind invitation and how many international respondents you have. You obviously, the whole world is watching Indonesia.
Time is yours. Live off. Here we go, Gede. It is show time.
Thank you all, and everyone be safe, and I hope all of you around the world, how many people you reach with this. It's great. It's a great service. You're doing a great job. My congratulations.
Time is yours. Live off.
Thank you very much. Konnichiwa, good morning. This is my first webinar using the Zoom. Thank you.
Time is yours. Live off. Applause. Godspeed, Dr. Firna Dwi Oktariana.
Thank you very much for a very kind introduction for me, Dr. Gede. I'm feel very honored to be here. Thank you very much.
Live off! Applause! Godspeed, Richard Hector.
Good morning, good afternoon, good evening, wherever you are. Thank you so much for asking me, Gede, to be part of this wonderful series of webinars that you've been doing.
And live off! Go ahead, Priya.
Thank you so much. I mean, I do not really have words to express how I'm feeling right now, but Dr. Gede Pardianto, I am totally blown out by this. Thank you so much for having me here and the entire Indonesian society.
Live off! Godspeed.
Thank you very much, my good friend, Dr. Gede. I'd like to thank Dr. Pardianto right at the outset for inviting me to this fascinating 1-hour Maestro session.
Time is yours. Live off. Applause.
Thank you. Thank you very much for this great introduction. I think it's the best introduction I ever had in my life.
Godspeed.
Thank you for such a warm welcome and alluring introduction. Thank you so much for this great opportunity and this wonderful webinar reaching out to everyone around the world. I'm amazed at all the people around the world.
4, 3, 2, 1. Time is yours.
Thank you very much, and my all kind regards to all Indonesian colleagues, and you have a beautiful country.
Time is yours. Lift off. Godspeed, Samuel Muscat.
Well, Gede and Cindy, thank you so much for the introduction and for the honor of being part of this really wonderful series that you put on. I must tell you, you have a very beautiful flag and a very, very beautiful anthem, so I was very happy to hear that.
Nothing else matters.
Cuando la tarde languidece, renacen las sombras, y en la quietud los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda. En el letargo de la noche parece gemir. Cuando la tarde languidece, renacen las sombras, y la que tú los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda. En el letargo de la noche parece gemir una pena de amor, una tristeza. Lleva el Santo Manuel en su amargura. Pasa incansable la noche moliendo café. Cuando la tarde languidece, renacen las sombras, y en la que tú los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda. En el letargo de la noche parece gemir una pena de amor, una tristeza. Lleva el Santo Manuel en su amargura. Pasa incansable la noche moliendo café. Cuando la tarde languidece, renacen las sombras, y en la que tú los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda. En el letargo de la noche parece gemir. En el letargo de la noche parece gemir.
Hello?
Hola, Jose.
Hello?
Hello. How are you? Fine. And how are you?
And thanks for this introduction. This is not a good time possibly to do it. We are out from the Champions League. We are out from the league. But anyway, thanks very much.
Okay. Okay. We are starting. Okay.
Okay. So I will start with.
No. We give introduction to you first.
Okay.
Okay. Thank you so much.
Thank you.
Cuando la tarde languidece, renacen las sombras, y en la quietud los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda. En el letargo de la noche parece gemir. Cuando la tarde languidece, renacen las sombras, y en la quietud los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda, que en el letargo de la noche parece gemir. Una pena de amor, una tristeza, lleva el Santo Manuel en su amargura. Pasa incansable la noche moliendo café. Cuando la tarde languidece, renacen las sombras, y en la quietud los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda. En el letargo de la noche parece gemir. Una pena de amor, una tristeza, lleva el Santo Manuel en su amargura. Pasa incansable la noche moliendo café. Cuando la tarde languidece, renacen las sombras, y en la quietud los cafetales vuelven a sentir esa triste canción de amor de la vieja molienda, que en el letargo de la noche parece gemir. Que en el letargo de la noche parece gemir.
Good afternoon to all the honorable doctors participating at this webinar. Good afternoon to you for our special guest today, Professor Jose Luis Guell, MD, PhD from Barcelona, Spain. Thank you so much for your time to share your knowledge in this International Ophthalmology webinar series, 1 Hour with the Maestro. I am Muhammad Alvin Marafi, a 10th grade high school student of Madrasah Aliyah Negeri Malang City, is Java, Indonesia, and I'm going to host and guide today's webinar as the Master of Ceremony. To all of our participants, absolutely, we are very happy to see all of you again in the 70th episode of our webinar series. At the end of this year, I mean, yes, in the last month of the year 2021, today, December 11. For this episode, this webinar series is still faithfully supported by Sabang Merauke Eye Center, or SMEC Hospital, Indonesian Ophthalmologists Association North Sumatra Branch, and Indonesian Doctor Association Medan and North Sumatra branches, and especially for this episode, all supported by Anak Sudarti Foundation Indonesia. To all of them that we have mentioned above, we are very grateful for their support. We would like to inform you as well that at this very moment, we have near 1,000 participants from 65 countries across 6 continents around the world, streaming from Zoom and YouTube. So now, let's start the webinar. Our speaker today is Professor Jose Luis Guell, MD, PhD from Barcelona, Spain. Professor Jose Luis Guell is a director of Cornea and Refractive Surgery Unit at the Instituto de Microcirugía Ocular de Barcelona. He is also a professor of the master degree program at Universitat Autònoma de Barcelona, Catalunya. And of course, there are many more achievements and important positions of his, as mentioned earlier in the slideshow of his CV, and which will be mentioned more completely later by our moderator. At this moment, he will present a topic with the title Lamellar, Keratoplasty, Anterior and Posterior, an online course. Audience, for today's webinar, our course director, Dr. Gede Pardianto, still become our moderator. And this time, Dr. Gede will be accompanied by Dr. Christina Bangun. As a co-moderator, she is a retinal surgeon, and both of them are from SMEC Eye Hospital, Medan, North Sumatra, Indonesia. And like the usual, this webinar will be divided into 2 sessions. The first session is an online course, and the second one is a Q&A session. So please feel free to drop your questions to the Q&A box. Once again, please in the Q&A box and not in the chat box. That is to make us easier to compile all the questions, so there are no questions that left behind to read to the speakers. Thank you for your cooperation. Also, for the participants who is joining this webinar in our YouTube channel, don't be hesitate to write your questions in the live chat feature. Our distinguished participants, before we begin this webinar, please pay attention to the Indonesian national anthem. Thank you. And now, please pay attention to the national anthem of Spain. Thank you as well. So now, the first session of this webinar will be started shortly, and I will give this session to our moderator and the co-moderator, Dr. Gede Pardianto and Dr. Cristina Bangun. The time is all yours.
Thank you so much, Raffi. Raffi is the oldest son of our friend, Dr. Fiona Zohra from Malang, Indonesia, more than 2,000 kilometers from Medan. And he is the youngest MC we have ever had. Assalamualaikum warahmatullahi wabarakatuh. Hello, hello, hola. Good afternoon and evening, Indonesia. Good morning, Barcelona, Catalonia, bon dia. Good day for our friends from all the rest of the world. It must be evening and night in Pacific, Australia, New Zealand, afternoon and evening in Asia, morning now in Europe and Africa, early morning in North America, Central America, and South America. First and foremost, thank you so much everyone for coming. Welcome to this international webinar that is attended by near 1,000 participants from 65 countries of 6 continents around the globe. We are gathering this day, all nations, citizens of the world, to be united for helping the people against blindness. Welcome our world best delegates. Welcome to our program, 1 Hour with the Maestro, for this amazing 17th episode. I'm Gede Pardianto from Indonesia, and this is Dr. Cristina Bangun. We call her Tina. She is retinal surgeon at SMEC Eye Hospital, Medan, North Sumatra, Indonesia. Ladies and gentlemen, the great maestro this time will be Dr. Jose Luis Guell, a legend, a grandmaster, friend of mine, the man, the leader of Europe, multiple awards winning, a great surgeon. Professor Guell is director of Cornea and Refractive Surgery Unit at the Instituto de Microsurgia Ocular de Barcelona. Jose is professor of the master degree program at Universitat Autónoma de Barcelona, Catalonia, Spain. He is past president of European Society of Cataract and Refractive Surgeon, and also past president of the European Society of Cornea and Ocular Disease Specialists, or EUCornea, scientific coordinator and professor of the Cornea and Refractive Surgery module, European School for Advanced Studies in Ophthalmology, ESASO in Lugano, Switzerland. He is editor of Journal of Cataract and Refractive Surgery, British Journal of Ophthalmology, Cornea, International Journal of Keratoconus and Ectatic Corneal Disease, Journal of EUCornea, Journal of Emmetropia, Journal of Cataract and Refractive and Corneal Surgery, and Journal of Ophthalmology. Eurotime Journal, Studium Ophthalmologicum, Cataract and Refractive Surgery Today Magazine, Ocular Surgery News, Refractive Surgery Quarterly, Noticiero, Eyework, and Journal of Optometry. He is awarded and decorated by several awards. Ramon Castro Viejo Award, Luramen Insignia Al Sociedad, Honorary Member of French Ophthalmology Society, Fyodorov Awards, ISRS Land Award, Menesu Quintana Award, Roland SICS SO Award, Jose Ignacio Barraquer Award, Great Singer Award, and he delivered several grand lectures. International Course of Cornea and Refractive Surgery in Acapulco, Mexico. Lecture in Emirate Society of Ophthalmology Conference. Ridley Medals, lecture in Copenhagen, Denmark. Lectures at Wills Institute in Philadelphia, Pennsylvania, USA. Santa Caterina Gold Medal in Siena, Tuscany, Italy. And 6th Annual Cornea, Cataract and Refractive Surgery Symposium, the University of Illinois, Eye and Ear Infirmary, Chicago, Illinois, USA, and Renal Medal Lecture in Brighton, United Kingdom. He has more than 700 papers in national and international meetings and conferences. He published more than 250 articles in peer-reviewed journal and several book chapters. And now he is going to deliver the Maestro lecture to near 1,000 participants from more than 65 countries of 6 continents around the world. Wow, that is so astonishing, outstanding. At this very moment, he will present a very important topic with the title Lamellar Keratoplasty, Anterior and Posterior. It will be a really captivating topic. Now we are learning from the man who is Grandmaster and true Maestro on this field. So be prepared. Fellow ophthalmologists, let's pay attention to Professor Jose Luis Guell. So Jose, we are counting down for you. 5, 4, 3, 2, 1. Time is yours. Lift off. Godspeed, Jose Guell.
Well, thank you very much for this huge and a little bit embarrassing introduction. Thanks very much to all of you. It is a pleasure to be here with you, and I will try to at least to be at the level of half of the terrible and terrific introduction. Thanks very much, Gede, and all the organization. So, could you see my screen?
Yes.
Yes.
See.
Okay, perfect. So I'm going to talk about lamellar corneal surgery. First, I will focus about 20 minutes on anterior lamellar, and afterwards I will talk about another 20 or 25 minutes on posterior lamellar. And well, I have no financial disclosures related with this talk. And let's review briefly the history. Anterior lamellar keratoplasty is obviously not something new. In fact, possibly the first transplantation, corneal transplantation, was a anterior lamellar transplantation performed by Mühlbauer in Germany at mid-19th century. It was then substituted by full thickness in most cases, and it was not until 1959 that it was the first attempt to expose descemet membrane. And the first actual reported exposure was in the 70s. So it is true that deep anterior lamellar keratoplasty, as we know today, is a relatively recent technique. The term DALK was originally described in 1984 by Eduardo Arenas Archila as at that time performed in a manual layer by layer dissection. Well, DALK has significantly improved its results during these last few years. And if we take a look to the most recent comparison between deep anterior lamellar versus penetrating keratoplasty, the results has significantly changed during these last 10 years. And I strongly recommend to you to review these particular publications that you can see at the screen, where the main advantage is preserving the host endothelial layer and taking into account that this cellular layer accounts for 90% of the possible rejection episodes after full thickness. You can imagine that this is the main advantage of deep anterior lamellar in any of those situations where the endothelial layer is healthy. So visual outcomes initially, let's say about 10, 15 years ago, were not as good as the ones that we regularly obtain with full thickness keratoplasty. But with the improvements of the technique for DALK, these visual results have significantly improved. And not only visual acuity, but also visual quality, as you can see on the right side in this article published at the Journal of Optometry some years ago. So today we can say that together with the immunological advantages of the technique in front of full thickness, there are no significant differences between both techniques regarding visual and visual quality results. So as it is basically highlighted, for example, in this classical book, the Manis Holland book in the last edition of 2017, the outcomes of anterior lamellar keratoplasty, the outcomes of DALK, are from an anatomical and biological point of view clearly better than with full thickness keratoplasty, and from a visual point of view equal as the ones that we can obtain with full thickness. These are some examples of patients who had in one eye, for one or another reason, a full thickness transplantation, and the other eye, a deep anterior lamellar. And as you can see, with the pass of the years, the endothelial cell loss is logically higher in the full thickness group, in the full thickness eye, compared with the deep anterior lamellar eye. So a clear advantage in the long term. So today, we can say that visual acuity and quality results are similar between both techniques, full thickness and deep anterior lamellar. Functional rehabilitation time is similar also because we still have these anterior sutures. The refractive change is also similar because of the same reason, but obviously chronic endothelial cell loss and number of possible rejection episodes after the surgery are much, much lower. So although there are still some indications limits, so when we have doubts about the host endothelial health, as in some cases of, for example, herpetic keratitis, or in those cases where we have a previously perforated cornea, such as in some advanced cases of keratoconus, there is no reason to not consider a DALK when the endothelium is healthy in any circumstance. Of course, the technique is not out of possible complications as any other. From a surgical surgical technique point of view, there has been several descriptions since it was first described by Eduardo Arenas in 1984. The use of to reach the decimet level, it has been suggested a technique of hydrodissection by Sujita in 1997. The concept of divide and conquer dissection by Tsubota in 1998. A viscoelastic dissection with a peripheral approach, something not exactly the same, but similar, what I will try to explain later on to you, by Meles in 2000. But it was really in 2002 when Ambar, our colleague from the Middle East, suggested the big bubble air dissection, when I think that DALK gets a significant advance and was possible to be performed by many other surgeons. And since that point, DALK started to really compete with full thickness keratoplasty regarding visual acuity results. After the description of Ambar, there has been some other improvements coming from Sarnicola, from Tan, from Fogla, and from many others, including Shimura and our technique that we published some years ago. And which is our technique? Well, basically, it's highlighted in this vignette. So we take this 2/3 of the anterior cornea and then inject viscoelastic to reach this decimet level, creating this big bubble. The concept is the same as the one suggested by Ambar in the 90s, in the early 2000s, but using viscoelastic. Obviously, using viscoelastic, you have some advantages. It's a slow motion dissection instead of a quick dissection. There is no fear in opening the big bubble because you already have inside viscoelastic, so there is no possibility of decimet membrane coming up suddenly. But the rest, obviously, of the dissection maneuvers are more or less the same as the one that Ambar described originally. So we have done what Subota also described as dissection in 4 quadrants, and we use our Katzin scissors in order to get a vertical cut at the periphery. So here we have decimet membrane exposed, and we can proceed with implant a cornea without a decimet membrane, so leaving the host decimet and endothelial cell layer in place. Of course, not always you can obtain this big bubble, as it happens with the air. Sometimes you only get this small bubble. So, but basically the concept is the same. You take profit of the area where you have the small bubble and start your dissection from there. You use your spatula to, in a slow motion technique, continue dissecting at this level. Obviously, the technique needs to be performed on a really soft eye, so you need to release constantly during the dissection maneuvers some liquid from the anterior chamber in order to do all your dissection maneuvers in a really soft eye, thus decreasing the rate of micro or macro perforations. So it's very important to use. This is Duas layer. And this is the pre-decimetic layer, Duas layer, that you can perfectly leave in place or leave it out. Obviously, any dissection above Duas layer makes the dissection easier. Sometimes the creation of the bubble is not so simple. So look at this case where we remove first these 2/3 of the growth, but then you inject viscoelastic, no big bubble. You inject several times, but at the end, you get the bubble, as you can see here. You check with the injecting a small air bubble in the anterior chamber that you have this posterior dissection, and then you continue. So sometimes it's not on the first attempt that you get the bubble, but you need several attempts, as it also happens with air. But one of the advantages I've mentioned in the beginning is that using viscoelastic, the view of the anterior chamber structures is much better. Then you remove the endothelium of the donor and proceed with the suture of the graft. Of course, if your operating room is equipped with a microscope OCT, you can check this step. So the injection of the needle, the depth of the injection can be better controlled with your OCT. And then what I consider the most important step in this technique, which is to decide, I repeat the video. So to know how deep is your insertion of your needle or your dissection, because the closer you are to the Duas layer, the best. So this is the most important step from my point of view. If you have an OCT connected to your microscope, you makes your life easier. In other steps of the surgery also will be very useful to have the OCT. Not a necessary tool, but a very useful tool if you're able to have it. Obviously, this technique, as when we use air, is not without possible complications. Look at this. In the case of the superior vignette, is an air dissection where we have had a perforation because of a rupture of the posterior descemet membrane at the time of injecting. And this may also happen with your viscoelastic dissection. Look on the lower video. In this vignette, look that we are not releasing viscoelastic. So the eye, now we have, look at that, we have broken the posterior descemet, and this is because the eye was too hard for the dissection maneuvers. So, of course, rupture, this is the small posterior descemet rupture in this case. These small ruptures, and I would say that also larger ruptures, does not necessarily mean that you need to convert to full thickness. We have the technique is robust enough to be able to continue despite of the rupture with a deep anterior lamellar, so without the need of transplanting the endothelium from the donor. You obviously will need to take some other measures, such as leave some air in the anterior chamber, as you do in posterior. As you can see here, you obviously need to have a peripheral iridectomy in any situation where in a phakic or pseudophakic eye you leave air in the anterior chamber to tamponate this this rupture, but you may continue without, despite of having a small or big ruptures. This is an example of such a situation. This is a keratoconic eye, a quite advanced keratoconic eye. We perform the dissection as usual. 2/3 of the anterior stroma are removed. Then we proceed trying to create the big bubble. You can see that in this case we got only a small central bubble. Precisely, could you see that we check with air, and we start dissection from this area, which is the thinnest area, obviously in this keratoconic case, and then we proceed with our manual dissection going from this central bubble, because the visco did not dissect the peripheral corneal layers. We need to do it with our spatula slowly, and sometimes we have some residual posterior stroma which we might leave in place. Usually is the safer option, but sometimes if you find another cleavage plane, then as you can see here, we will continue trying to be a little bit deeper, because obviously the deeper, the best the final visual results. So we continue with the dissection, but sometimes going deeper, as we mentioned, you might have a rupture. You will see now that in one of these maneuvers, now, boom, we have the rupture. A quite long rupture. It goes from our 2 to our 7. You can see that immediately the SMEC tries to roll. But as I mentioned, despite of having a big rupture, you can still positioning the posterior membrane. You can still use a donor without endothelium. As long as you do an inferior iridectomy, you leave some gas, 20% SF6 in the anterior chamber, in order to have a proper position of the host SMEC against the stroma. But obviously, as you can see, sometimes this adhesion in the first post-op days is not as good as we wish. So sometimes we need to repeat a couple of times the injection of air. But in this case, we need to do it twice. But at the end, we were able to, despite that you can see on the lower photography, you can see a white break in decimate. Cornea clears up with a very good vision 3 months post-op. So no problems of having a big rupture. You still can consider to go and do a DALC. So in summary, DALC, descemetic or pre-descemetic, as long as you leave less than 80, 90 microns posteriorly, is a technique of choice when keratoplasty is indicated and the endothelium is healthy. Best corrected visual acuity and quality are the same as full thickness, but obviously a longer survival. DALCs, in the case of keratoconic eyes, you still may have recurrence. And in fact, the published work shows that it might be earlier in anterior lamellar than in full thickness, although this is not clear. But this opens the concept of doing cross-link in those keratoconic eyes immediately or some months before you proceed with your keratoplasty procedure. Of course, for DALC, there are limitations. When we have doubts about the endothelial health, when we have a very thin or previously perforated cornea, still some limitations, but each day less limitations for most anterior lamellar surgeons. Visco bubble dissection is my favorite technique because it's less aggressive from my point of view. You have a slower and more controlled dissection, and you have a safer steps and better visualization. Although, obviously, it will need to be demonstrated with properly designed comparative studies, something that has not been yet done. And, of course, to have an intraoperative OCT is helpful, not mandatory, but it's helpful. Well, thanks very much for your kind attention. So if we can have, if you wish, some questions. If not, I can move directly to the next posterior lamellar part of the section. What do you think, Gede? Gede?
Go ahead, go ahead. Please carry on.
Okay, so now we will move to the posterior lamellar keratoplasty. Let me see if I can move this. Oh. I don't know how I can put full screen. Well, I don't know how we can do full screen because I cannot take this out. I'm sorry. Yeah.
Maybe you close the previous.
That's it.
Okay.
Excuse me. Yeah. So again, no financial disclosures. And this is just a graph showing the trends in posterior lamellar keratoplasty. And as you can see, and much more elsewhere in the world, significant than deep anterior lamellar. So posterior lamellar has almost substituted full thickness keratoplasty when we have a endothelial problem. So in most circumstances worldwide, when the anterior stroma and the anterior corneal layers are healthy, but the problem is in the endothelium, the endothelial keratoplasty techniques have already substituted full thickness transplantation. Look at the figures that you can see from our US colleagues, but this is similar what has happened in Asia and Europe regarding posterior lamellar. And this trend, obviously, and because of the surgical technique difficulty, has not been so significant, as I mentioned before, in anterior lamellar, but has been huge in posterior lamellar. So there has been an evolution also in endothelial keratoplasty techniques. It was in the late 90s, early 2000s, that first of all, Meles with his PLK technique, and immediately after Terry Mark from US with his DLEK technique, that started with this, let's say, way, or let's say these endothelial keratoplasty techniques. At that time, it was relatively tough and difficult to create the dissection both in the host and the recipient and the donor. So that's why this technique was not adopted by many other surgeons. But, and look at the red asterisks, these are the two key stones from my point of view that made possible that endothelial keratoplasty was adopted by many other surgeons in the world. The first one is the use of the microkeratome. This was suggested by Massimo Busin, and he published his first results in ophthalmology in 2000 with a technique that you can see in this small vignette, where in this case is myself. I am obtaining the donor using the microkeratome, so a first very deep cut in a donor globe, then a trephination of the posterior layers. So in this relatively simple way, we obtain this posterior lamellar layer, much simpler than with the technique, dissecting technique proposed by Meles and Terry in the 2000. Then we did the same in the host, as you will see. So we took, this is the host, the patient with endothelial decompensation, pseudophakic eye. So we create this very deep lamellar cut with a hinge, similar to the one that, except that it was much deeper, the one that we used for LASIK at that time. Then a posterior trephination, and then a transplantation of this posterior layer. So the surgery was much simpler. Unfortunately, and despite that anatomically the results were excellent, at least in my hands, the visual results were not able to compete with the visual results we got with full thickness keratoplasty. And again, this technique was not followed by many other surgeons, although it was a first step, the use of microkeratome. But immediately later, in 2004, Garrett described the concept of descematorexis. And I think that this second keystone was what made possible the explosion of endothelial keratoplasty techniques in all the world. So it was not only simple to obtain the donor lenticle using the microkeratome, but it was also simple to prepare the host to receive this donor. So this technique, originally called the SMEC or the SAG, when you use an automatic instrument to obtain the donor lenticle. You can see this vignette. This is a video from my friend, an excellent surgeon, Sadir Hanoush from Philadelphia. This is a surgery that he performed, in fact, in a live surgery session in Barcelona years ago. And as you can see, this is the descematorexis concept proposed by Garrett Mellis. So we remove only descemet layer, preparing the host, and then we introduce the donor, originally with forceps, later on with different injectors. But so this has been refinements, obviously, of the technique, but the concept technique, so preparing the host with a descematorexis and injecting the donor obtained using the microkeratome made the surgery so conceptually simple and extremely effective that from that moment, the endothelial keratoplasty became a technique able to quickly compete with full thickness. Obviously, the idea also coming from Garrett that what we did in the host, we can also be able to do in the donor. So transplanting not a thick posterior lamellar dissection, but a descemet layer. So what we call descemet membrane endothelial keratoplasty was the last part of the evolution of this lamellar endothelial techniques. So endothelial keratoplasty in any of their forms is obviously superior than full thickness keratoplasty for endothelial dysfunction because it's safer. We preserve globe integrity. We have fewer activity restrictions for patients after the surgery, obviously. We have a better, but most important, a faster visual recovery after the surgery. And we have obviously fewer anterior surface aberrations and a much less refractive change. Of course, in situations like the ones that you can see on the right side of the screen, in a photography and in a surgical case, there will be a number of cases where you will not be able to do a posterior lamellar surgery, so endothelial keratoplasty, because the transparency or irregularity or both of the anterior stroma and the anterior cornea is not good enough to be solved simply with a EK technique. So full thickness will be an option, a needed option for many cases still, but in any other situation where the anterior cornea is healthy, endothelial keratoplasty has completely substituted these techniques or full thickness keratoplasty. Obviously, in between the different techniques, the MEC looks like significantly better for patients than the SMEC. Vision is as good as in normalized, so the number of 20/20s is higher, generally speaking, in the MEC than in the SMEC cases. We have for the same reason, a more rapid visual recovery and a fewer posterior corneal higher order aberrations induction. More important, the risk of immunological rejection is also lower, and this is because possibly the lower the amount of stroma is transplanted, the lower the possibility of having a rejection episode afterwards. We have a better optical quality also, and all these assumptions obviously are with the available data. Of course, this can be discussed that if the new or the latest midterm results with ultra thin the SMEC can definitely compete with the MEC, and well, this it would be debatable, but anyway, the thinnest we all agree that is the best. Obviously, the main limitation with the MEC still was in the beginning and still is the rebubbling rate. This was the reason by what in 2009 we proposed, as many other surgeons was introducing their own tricks. So we proposed this, what we call advanced technique, which is a bimanual technique using this bimanual to decrease the intraocular manipulation time. So originally, the manipulation time once we have the lenticle inside the eye was relatively long, and this bimanual technique allows us to do this quite quick. And also we propose the use of SF6 20%, as corneal surgeons have done previously in other circumstances. This is a non-expansive concentration which allow us to have a bubble inside the eye for 5-6 days. So it was a kind of a daily rebubble for 5 days. So using this technique, we were able to significantly diminish the rebubbling rate. As you can see, this is the main tricks of that technique proposed in 2009. So a wide hose destigmatorexis, inferior uvectomy, no viscoelastics used, and used a 20% SF6. And this bubble was used in the first 5 post-op days, alternating head positioning. So this was let's say a trick to diminish significantly rebubbling this in our hands. It was a suspicion that SF6 was not going to be toxic. It was demonstrated later by some colleagues that there was no differences in endothelial toxicity between the use of air or SF6. And again, it was demonstrated because we suggested to leave the eye relatively soft. At that time, in the late 2000, the tradition coming especially from the SMEC was to leave the eye sometime with very high pressure, but it was also demonstrated later that there was no evidence that higher IOP values at the end of surgery enhance graft adhesion, resulting in lower remodeling rates. So I don't think it's necessary to leave any time very high pressures to improve or to diminish remodeling. So we perform a comparison between using SF6 or using air regarding endothelial cell loss and visual acuity results, and there were no significant differences except in the remodeling rate. In our hands, in this prospective study, we have a almost 3% against and almost 13% of remodeling rate when we used in pseudophakic eyes SF6 instead of air. So I think that this here is the standard technique. I just will leave the video because I would like you to see there are many ways to manipulate the donor, and there are many other ways to introduce the donor in the anterior chamber. There are several injectors suggested. This is the one that I'm using. I just want to, this is a silicone tip cannula, the same one that our colleagues in retinal surgery used to give sometimes massage and touch the retina. So I presume that this, if it was not dangerous for the retinal cells, why should it be for the endothelial cells? That's why I'm using this to touch the lenticle. But this injector allows to introduce the lenticle inside the eye in a quite slow motion. So that's why through a 2.4 incision, we can introduce the lenticle inside. And then with this tap-tap technique that most of us have adopted in a relatively soft eye to open the lenticle. And then we inject, would properly position the lenticle in the center, and then inject SF6 20% to reposition the eye. The use of SF6 has been defended by many surgeons worldwide. Some others still think that there are no differences, but I would say that most surgeons are in favor of using, as you can see in this review of the literature. So the MEC, just to finish my talk, is also possibly our best option to use as a technique to restore chronic endothelial cell loss after full thickness keratoplasty or after other posterior lamellar techniques. So there is no need to replace a full thickness graft in order to, when we have a chronic deficiency of endothelial cells, you can do a DMEC to restore these previously full thickness grafts. You can consider to do desematorexis, a central one, or you can do, as you have seen in the left superior video, you can escape from doing this posterior desematorexis. On the right superior video, we are doing the central one. I don't like to do a desematorexis reaching the area of the old penetrating wound, because I think that if you traumatize this posterior wound, you might have problems during the surgery. So if you decide to do a rexis, my recommendation is to do it inside the graft, but not affecting the posterior wound. And obviously, this is the technique of choice for the neck or the side failed. Also, is a very useful technique when we use it combined with our glaucoma colleagues. You can see on the left video a combination of the neck with a non-perforating glaucoma surgery. And you can see the MEC on the right side video in an eye with a tube in the anterior chamber. We will shorten the length of the tube, but the MEC is also our favorite procedure when a keratoplasty is needed and the anterior cornea is healthy. It's still our favorite procedure in combined surgeries. You can see here that obviously the technique for the MEC changes a little bit in this combined surgery, as you can see on the left superior video, because the eye is much soft, so maneuvers are slightly different. But basically, you will do a similar work. As it happens also in aphakic eyes, you will need to deal with the bubble in a different way. And sometimes the bubble disappears during the first 48 hours in those eyes where filtering procedures. So the rate of rebubbling is slightly higher in this particular group, but still it's a very good option. So EK techniques have significantly replaced full thickness worldwide for the management of irreversible endothelial failure, with well-supported advantages, as we have mentioned before. The MEC has also demonstrated superiority over the SMEC, although, as I also mentioned, ultra-thin techniques may probably diminish such a difference, and we need to wait for these mid-long-term results of these other techniques. It has become my standard in managing endothelial failure, also in special circumstances such as keratoplasties, in glaucoma surgery, etc. As I mentioned, there are obviously still some limitations under investigation, such as in aniretic eyes, aphakic and vitrectomized eyes. So the technique is much more difficult, and I can understand that some surgeons prefer, instead of making their lives difficult, to take the option of thickness. At the end, we need to do what is best for our patients and not be too much obsessive in following a particular technique. Of course, we still lack of long-term, 10, 15 years, to check reoperations rate, for example, compared with other techniques, as well as short-term and long-term data in using other options which are on the pipeline, and I'm completely sure that will substitute our actual approach to endothelial failure, such as injectable cell stimulators, cell injection therapy, tissue engineered EK, or Descemet stripping only, or Descemet membrane transplantation, selective endothelial removal, and gene therapy modalities. I am especially interested in this last option, such as antisense oligonucleotides and clustered regular interspace short palindromic repeat space gene editing. These long names or others in the gene therapy world, I'm pretty sure that will substitute, especially in the dystrophic group of patients, will substitute surgery in the future. Of course, it will not be completely substituted because there always will be post-traumatic cases and some others, but at least in the dystrophic group, in the Fuchs, in the posterior polymorphous, I'm pretty sure that gene therapy will be able to substitute surgical techniques. So thank you very much for your attention, and I am open for any if needed.
Thank you so much. Thank you so much. What a fascinating lecture, Jose. Remarkable presentation. That was incredible. So, fellow ophthalmologists, now we are approaching the question and answer session. May Tina help me to read its question to the Maestro. Tina, please.
Okay, Dr. Gede. Professor, I have one question from Dr. Valentina Berrios. Thank you for the presentation, and I have a question. Could we use Visco after the big bubble? I mean, first inject air and then use Visco. Can we?
Yes, of course. I would say that this is the most common approach worldwide, and this is a fantastic option. I still prefer to use Visco since the beginning, but if you prefer to use air, then there are two tricks for the use of Visco when you have used a big bubble with air. The first one is to put a small drop of Visco in the center immediately before you open the air bubble. This small portion of Visco diminish the speed of the air going out from the bubble, so diminish the risk of having a problem when you introduce your knife. And immediately after you have this small central opening, yes, to inject viscoelastic inside this air space is a fantastic option. Yes.
Thank you, Jose. The next question is from Brazil. What formula do you suggest to calculate IOL power for post-keratoplasty patient?
Well, this is another good question. I must say that this will depend mostly on the stage that I'm going to do the cataract procedure. So, and in the case that that we are dealing with that. So if I am going to do cataract surgery during the first few months after the transplantation, independently that I've done a deep anterior lamellar or a full thickness transplantation, usually I use SRK formula. But if I'm going to do a cataract surgery on an eye who had a corneal transplantation years ago, so it's simply a new, so I will use the same formulas I'm using after corneal refractive surgery. So in my case, I use the True K formula or the Barrett formula.
Okay, Professor, the next question is from Malaysia, and I think it is actually a little out of topic, but do you have any recommendation on how to give first aid to patients with severe corneal injury due to caustic soda?
Well, this is something that we can be talking for hours, because obviously depends. So let's in order to be quick, the most important thing I would say is the strategy in the acute phase. So if we all be able to, in the acute phase, so during the first 30 minutes after the burn, to use a couple of liters of tamponification liquid to put over the corneal and over the ocular surface, cleaning and tamponizing the effect of the burn. And we do this for let's say 10-15 minutes with a couple of liters of this specially prepared liquid, or at least with serum. This first maneuver, and immediately after, to apply over the corneal surface and over all the ocular surface amniotic membrane in the really acute phase. This would possibly significantly diminish the acute damage over the ocular surface structures. Having said that, what we can do in a later stage will strongly depend on the degree of necrosis, degree of damage of the limbal stem cells, extension of this damage. So will depend on many things, coming from using some antibiotic and immunomodulator drops and being enough, or going to a the need of a heterologous limbal transplantation, or the use in some cases of a K-Pro. So the range of options will depend on the individual situation. But I would highlight the relevance and the importance of the very acute strategy. Water, if possible, a special prepared water, but if not water, 30 minutes or 10, 15 minutes cleaning, and in the acute phase to put amniotic membrane of the ocular surface.
Thank you so much. This is from Yemen, Professor. What kind of drugs to manage pain during and after corneal surgery?
Excuse me, could you repeat the question?
What kind of drugs to manage the pain during and after corneal surgery?
What kind of drugs?
Yes.
Well, I think that we all agree in using basically antibiotics and steroids. The way that we use them topically might be different from one specialist or other. My suggestion is in anterior lamellar to do what I regularly do in full thickness, which is in the first few days to use 6 times per day, and then come after a couple of weeks to 4 times per day a steroid and antibiotic drop, and then diminish during the next few months. I am much more aggressive today in endothelial transplantation, giving about 8 or 9 times per day during the first 5-6 days, and then again doing a taper following the next weeks and months. And my suggestion, not in anterior lamellar, but in any technique that we transplant endothelium, which is full thickness and endothelial keratoplasty techniques, is to leave forever at least a 1 drop every 2 or 3 days of steroid. So that's my standard.
Thank you, Professor. The next question is from Lau. When do you use patching and contact lens after corneal surgery?
Well, not in most circumstances, except in those where I have a significant epithelial defect. So I would say that, for example, in the MEC, in most cases, I use a bandage contact lens for the first 5-6 days, because in most cases I remove the edematous epithelium during the surgery. So on the first post-op day, I have a significant epithelial defect. But in full thickness or anterior lamellar, if the quality of the remaining epithelium of the donor is good enough, so I do not have a significant epithelial defect, I very much prefer not to use a bandage contact lens unless I have symptoms.
Thank you so much. This is from your compatriot from Spain. How long you give permission to patient for cycling and swimming or do sport after surgery?
A good question. Generally speaking, after 1 week. And I know that this is not shared by many of my colleagues worldwide, but generally after 1 week. Of course, there are exceptions and different particular circumstances, but I would say that in most cases where there has not been any additional problem or any additional surgery, usually after 1 week.
Okay, thank you, Professor. The next question is from South Africa. Do you have any experience to treat dexamethasone?
Well, of course, dexamethasone is a problem for all of us during anterior segment surgery, and again, there is not a single approach. In some cases, we will need to do a emergency surgery. So in order to wait to have a adequate corneal tissue to proceed with the final surgery. In some other cases, depending on where you live and your access to proper corneal tissue, you can take this decision on the same day you receive your patient. So this will not be the same in Barcelona than in other places in the world. But and there will not be the same. A small dexamethasone and a huge one, it will not be the same. But the concept is that, first of all, you need to create measures to diminish the possibility of having a perforation. So you might need to use drugs to diminish the intraocular pressure. You might need to put some glue or a contact lens, as I mentioned, to wait until you have corneal tissue to manage. In many cases, once you have the corneal tissue, you will be able to do a deep anterior lamellar if the endothelium is healthy, because you might have a dexamethasone in a patient where the endothelium it is not healthy, and so at the time of considering your keratoplasty procedure, you will need to do a full thickness keratoplasty. So as I mentioned, there is no single recommendation. You will need to manage individually, depending on the status of the endothelium, depending on the status of the eye, depending on the status of the rest of the ocular surface. So no single measures for all dexamethasone. No?
Thank you, Jose. The next question from Sri Lanka. When you remove the suture, if any, in any corneal procedures?
Well, I would say that obviously after a SMEC, where you have used only 1 or 2 sutures, I used to remove them after a 3-4 months period, usually. No, sometimes earlier, because the wound is 2.4 to 3.2 in length. So, but after an anterior lamellar or full thickness where you have 16 or 24, depending on the case, I start considering removing them. Well, obviously you will need to remove them or any of them anytime they are loose or they are infiltrated. So when you need to take them, you will need to take them out. But if they are okay, I start to consider removing them after month 3, and then I do regularly, depending on the corneal astigmatism, in order to control this astigmatism during the first 18 months after the surgery. Usually, I remove all the sutures. In most cases, again, there are exceptions, but in most cases, during the first 20-24 months.
Okay, Professor, I have 2 questions from Dr. Ahmad Nur Fahmi from Malaysia. The first one is, dear Professor, What is the best way to approach a case of pseudophakic bullous keratopathy due to anterior chamber IOL? Is it stage procedure, the MEK versus the EAAK? And how about the choice of IOL placement? The second question, and about DARP with micro or small perforation, how to prevent from double anterior chamber perforation occurring partly because by injected bubble pass through the perforation area? Thank you.
Well, again, a couple of questions able to be for a long talk. Well, regarding the first one, again, this is not a single response, because a patient who has a chronic endothelial significant loss and is with a phakic IOL, the decision of what to do will depend. Well, we definitely will need to take the lens out if we are sure that this was the reason by what the endothelium was decompensated, and we will need to do an EK procedure, the one that you prefer. But if at the same time we might consider to put another phakic IOL, or if we might consider to do crystalline lens surgery implanting an IOL, and if we do so, which kind of IOL we are going to use, this needs individually an individual decision. So I would not do crystalline lens surgery if I am in this situation on a 36 years old individual, because I don't want to do crystalline lens surgery unless there is no opacity in a so young individual. I would definitely do crystalline lens surgery. At the same time, we are removing the phakic IOL and doing the endothelial transplantation in a 65 years old myope or hyperope. So as I mentioned, what we will need to do in most cases is to remove the lens who we consider that is the main reason for such a damage to the endothelial cells, and to proceed to an EK procedure. The other things that we will decide to do will depend on the case. No? And regarding the second question, as I tried to explain during my lecture, if I have a micro or macro perforation, I would say that today, in most circumstances, I will not switch to full thickness. But of course, you will need to use gas in the anterior chamber to properly position this broken decimet against the donor stroma. And for such a strategy, you need to, at the surgery, perform a peripheral iridectomy. So I would not leave simply a small bubble and use sarcoplegia. So I strongly recommend to leave a big bubble, at least 80% of the anterior chamber volume, with a peripheral iridectomy. And with this, you should be able to manage, in most cases, these small or big ruptures.
Thank you, Professor. The next question will be from Italy. What antibiotic of choice do you choose to treat post-corneal procedure infection?
The one that I regularly use is the one that comes with my combined topical drug, and in general, for the last few years has been an aminoglycoside, either cobramycin or neticillin. Today, in the but I do not care as long as it's a broad spectrum antibiotic. So using quinolones would be also a good option. So, but generally speaking, I've been using aminoglycosides because the drugs I've been generally giving together with the steroids are aminoglycosides.
Okay, Professor, the next one is anonymous. If we have a patient with descemet membrane detachment after cataract surgery and after being given air bubble, the visual acuity still did not improve, is it possible to give SF6, F6 or C3F8 gas in the anterior chamber to improve the condition of the descemet membrane detachment? When is the best time to do the MEK? Thank you.
Well, if you have a descemet detachment during cataract surgery, you might have different possible situations. You might have a detachment, but the descemet membrane is still in place. You might have a detachment, but the descemet membrane was lost. Second, you might have any of both. So a detachment with the descemet in place, or with a piece of descemet lost, without any corneal edema, or just a transitory corneal edema that is improving over the next few days. So in those cases, I will not do nothing. Obviously, there is no need to do nothing. But obviously, if this edema does not resolve, if you still have descemet there, but detached, the best option is to use a small bubble as FS6 20% and position in the next few days to your patient properly in order to have the membrane properly attached. And this is not a simple procedure because you should do it, the injection should be done immediately inside the fold of descemet, because if not, if you put the bubble and you don't do it properly, you might have a positioning inverse of the membrane. So it's not a stupid thing to be done. So I strongly recommend to do in the operating room and controlling what you're doing. But of course, if you do not have this piece of descemet, and so you have an area without descemet and you have edema that is not resolving spontaneously, then you might consider to do a mini SMEC procedure. This has been described by, I think that the first ones to describe that it was our colleagues from Cologne, from Germany. But anyway, this is an option that I've done in these cases and in other cases where there is areas where descemet is not working and you have edema, because sometimes you do not have edema.
Thank you, Professor. The next question from Australia. Do you have any patient experience saying that second eye surgery is more painful than the first eye, and why?
Well, I will respond to that, but I must tell you that I need to leave in a couple of minutes. So I'm very sorry. If there are more questions, I can respond through the mail or whatever. But I am very sorry, but this is 11:30 and I need to go down to the operating room.
Okay.
Anyway, could you repeat the question? Excuse me.
Do you have any patient experience saying that second eye surgery is more painful than the first one, and why?
Well, I possibly yes. I have some patients that mentioned this, and some others that mentioned that the first one was more painful. There is no rule. We have patients saying different things, which might be related with their own sensation. Let me tell you that if I am talking on on transplantation surgery, this has not been for me an issue at all, that the first eye did more pain or not. This is an issue for cataract surgery or phakic IOL surgery. And perhaps this is what my colleague making this question is thinking on. Sometimes when we do consecutive surgery of one eye and the second eye after 2 or 3 days, the effect of the systemic and topical drugs, but especially the systemic drugs, are a little bit less powerful. And it's relatively common for those patients who had consecutive surgery separated 2 or 3 days to mention that they have been much more aware of the surgical steps on the second surgery than on the first. And I think that this is related by the less effect when it is so close one surgery to the other of the systemic drugs used by the anesthesiologist.
Thank you so much. That's the last question for you. Thank you so much. Thank you for this memorable lecture and very noble information you have shared with us this afternoon till evening in Indonesia. That is so exceptional. Fantastico. Thank you so much, Jose. Thank you. Thank you.
Bye, Professor.
Thank you to all of you.
Please
Thank you for your invitation. It has been a pleasure. Thanks very much.
Thank you so much. Thank you. Thank you so much, Professor. And everyone, thank you so much for your kindly attention this afternoon until evening today in Indonesia. Thank you SMEC Group, thank you ID, thank you Perdami Sumut, Anak Sudarti Foundation Indonesia, thank you all committee, and thank you Tina. Thank you so much. And everyone, see you on the next 1 hour with the Maestro. Thank you, my distinguished friend from all around the planet. And further, after 15 episodes, truly, indeed, you are the best in the world. Here we are, spreading love, care, peace, and tranquility on earth. Stay healthy, everybody. Stay wealthy, stay happy. Thank you, everyone. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. And then Raffi, the youngest MC we have ever had. The time is all yours. Thank you so much.
Thank you, Dr. Gede. All right, and so we have arrived at the end of this webinar. We really hope our webinar today will enrich our knowledge about the topics. Once again, we would like to appreciate for Sabang Merauke Eye Center, Indonesian Ophthalmologist Association North Sumatra Branch, Indonesian Doctor Association Medan and North Sumatra branches, and to Anak Sudarti Foundation Indonesia for supporting this event. Our deepest gratitude as well to Professor Jose Luis Guell for his amazing lectures, to Dr. Gede Pardianto as the moderator, also for Dr. Cristina Bangun as the co-moderator, and absolutely to all of our distinguished participants for your enthusiasm in this webinar. And like the previous episodes, your e-certificate will be sent to your email a few weeks after this webinar. We also suggest to you all to please check your email spam folder in case the certificates sent in there. Sometimes it happens. We would like to inform you as well that for the upcoming year of 2022, our webinar series will come with a new platform, but definitely with the extraordinary maestros as our guests. The information about our webinar series for next year will be delivered soon by email to all of you. We appreciate so much for all of our loyal participants who always continue to follow and support our program. And while waiting the information for next year, please don't forget to subscribe our YouTube channel, 1 Hour with the Maestro, so you can always watch and learn again and again this episode and all videos from the previous episodes of our webinar series. I am Muhammad Alvin Ibn Rafi as a Master of Ceremony on behalf of the entire committee, We want to say thank you so much for your participation to our webinar today, and goodbye. Have a good day, everyone.
Di Indonesia, menuju Indonesia maju sejahtera. SMEC Group majulah, SMEC Group jayalah, SMEC Group pilihanku, SMEC Group untuk bangsaku.
song with all of my friends, and we're from Barcelona. Love is a feeling that we don't understand, but we're gonna give it to ya. We'll aim for the stars, we'll aim for your heart when the night comes, and we'll bring you love. You'll be one of us when the night comes. Hang with him. We'll aim for the stars, we'll aim for your heart when the night comes, and we'll bring you love. You'll be one of us when the come here, na na na. Tack så mycket.
I'm from Barcelona. Hej Emanuel. Hej med hit borta.
Kapal di Indonesia, menuju Indonesia maju sejahtera. SMEC Group majulah, SMEC Group jayalah, SMEC Group pilihanku, SMEC Group untuk bangsaku.
We're so excited to tell you that at this moment, we have near 1,400 participants from 85 countries and 6 continents around the world.
That at this very moment, we have nearly 1,000 participants from 63 countries across 6 continents around the world.
We are so excited to inform you that at this very moment, we have more than 1,000 participants from 76 countries across 6 continents.
So we are very, very excited to inform you that at this moment, we have more than 1,000 participants from 74 countries across 6 continents around the world.
We would also like to inform you that at this very moment, we have more than 1,000 participants from 81 countries across 6 continents around the world.
We would like to inform you as well that at this very moment, we have nearly 1,000 participants from 65 countries across 6 continents around the world.
We would like to inform you as well that at this very moment, we have near 1,000 participants from 61 countries across 6 continents around the world.
Time is yours. 5, 4, 3, 2, 1. Lift off. Let's go.
Thank you very much. It's been a great pleasure to speak with you. Nice to meet you over Zoom. It's interesting that we meet people now across the world all the time.
And lift off. Give applause to Amar Agarwal.
Thank you very, very much, first of all, to entire Indonesia and also to all the 1,400 delegates watching from 85 countries.
Applause. Godspeed, New Jersey.
Thank you very much for this extremely kind invitation and of course a very beautiful introduction. Thank you very much.
Time is yours. Lift off. Ahead, Boris.
Thank you very much. First of all, I want to thank Gede, Pardianto, and all Indonesian ophthalmologists that were being so kind to invite me.
Applause.
Thank you so much really for organizing something like this, because it really kind of opens up so many channels of education.
Applause.
Thank you very much for the very kind invitation and how many international respondents you have. You obviously, the whole world is watching Indonesia.
Time is yours. Flip off. Here we go, David. It is showtime.
Thank you all, and everyone be safe, and I hope all of you around the world, how many people you reach with this. It's great. It's a great service. You're doing a great job. My congratulations.
Time is yours. Lift off.
Thank you very much. Konnichiwa, good morning. This is my first webinar using the Zoom. Thank you.
Time is yours. Lift off. Applause. Godspeed, Dr. Firna Dwi Oktariana.
Thank you very much for a very kind introduction for me, Dr. Gede. I'm feel very honored to be here. Thank you very much.
Lift off. Applause. Godspeed, Richard Hector.
Good morning, good afternoon, good evening, wherever you are. Thank you so much for asking me, Gede, to be part of this wonderful series of webinars that you've been doing.
And lift off. Go ahead, Priya.
Thank you so much. I mean, I do not really have words to express how I'm feeling right now, but Dr. Gede Pardianto, I am totally blown out by this. Thank you so much for having me here and the entire Indonesian society.
Lift off!
Thank you very much, my good friend, Dr. Gede. I'd like to thank Dr. Pardianto right at the outset for inviting me to this fascinating 1-hour Maestro session.
Time is yours. Lift off.
Thank you. Thank you very much for this great introduction. I think it's the best introduction I ever had in my life.
Godspeed.
Thank you for such a warm welcome and awe-inspiring introduction. Thank you so much for this great opportunity and this wonderful webinar reaching out to everyone around the world. I'm amazed at all the people around the world.
4, 3, 2, 1. Time is yours.
Thank you very much, and my all kind regards to all Indonesian colleagues, and you have a beautiful country.
Time is yours. Lift off. Godspeed, Samuel Musket.
Well, Gede and Cindy, thank you so much for the introduction and for the honor of being part of this really wonderful series that you put on. I must tell you, you have a very beautiful flag and a very, very beautiful anthem. So I was very happy to hear that.
Nothing else matters. Una bandera en Jerman.